I am a 2019 general psych grad, and recently transitioned from full faculty to adjunct doing private practice. I'm working with Sam Weiss to put these alumni webinars together monthly and trying to focus on topics that are pertinent and relevant and helpful to all groups of people, whether you're a researcher or a clinician or in private practice, government, hospital-based, wherever. And these, we can learn from each other and really impact our practice in a big way. So although September is coming to a close, we all know that this month does serve as a great time to talk about suicide prevention awareness, as it's kind of dedicated for this month. At the end of the day, no matter what demographics we serve or specific diagnoses we treat or investigate, as mental health clinicians and researchers, we're at the core of our business really is eradicating suicide at its roots. So the various factors of suicide and how we can prevent this from different perspectives and demographics and diagnoses, it's all really important and sometimes really nuanced that we sometimes miss. And we're lucky enough to have a lot of folks at UNC who are more subspecialized who can share those nuances with us. Like I said, please remember that this monthly webinar is supposed to be interactive, so don't be shy. You know I will not be, so be prepared for that. And with that, you guys can feel free to chat in the chat box if you prefer. We'll try to keep an eye on that, but also feel free to interject, and otherwise, microphones off if you can. We do have some awesome speakers tonight, and some of them have already been talking a little bit. I'll introduce them briefly. First up, it sounds like we have the wonderful Dr. Echo Meyer. She's a child and adolescent psychologist and professor within the Department of Psychiatry. She is the founder and co-director of the Gender Wellness and Equality Clinic, GWE. And within that, she's going to teach us and talk with us tonight about suicide prevention within the transgender population. I've noticed for myself, this is a highly referable population. There's just not enough clinicians serving this population, and there's a lot of fear, I think, around serving them and serving them the wrong way or missing things. And so I've tried to expand my knowledge base on this population and how I can better my own care. And so hopefully tonight, Dr. Meyer, you can help out with that even more. Give me some cliff notes. Next, maybe between Dr. Hutto and Dr. Vitiello, we have Burt Hutto, psychiatrist and professor at UNC, director of the Crisis and Stabilization Unit for Neurosciences, and director of the Resident Program Psychotherapy Education component. Staple within the department, hard pressed not to know Dr. Hutto along the journey if you've spent some time there. And I would imagine probably one of our department's specialists in suicide, or at least the aftermath, picking up the pieces for patients who attempt or get near completion for suicide attempts. So gonna hopefully be hearing from him tonight. Here, some lovely slides are in chat. Last but not least, we have our newest alumni, one of our newer alumni, Dr. Evan Vitiello, who's recently rejoined as faculty at UNC, went off to do his consult liaison fellowship and came back and is going to review the ASQ suicide screening initiative at UNC, which is novel to me. I've not heard anything about this, so I'm looking forward to learning what that is and what it does for us. So take it away, guys. Thank you so much for joining us and for speaking tonight.
Thanks, Rachel. So I'm just going to kind of, like you said, lay out a little bit of information to kind of get food for thought going, and then turn it over to Evan and Burt and kind of go from there, I guess. I've not done this before. So I think it's a really telling time, right? As an adolescent psychologist today, I don't know if anybody's been following the news a little bit, but those of you who work with adolescents in particular, there's been a lot on the news today about suicide, right? The Facebook, Instagram information came out. Some numbers to just think about is since 2010, suicide completions have increased quadruple-fold between born females between the ages of 10 and 14. So it's a younger group than we traditionally have thought about. And it's what the research is coming out of Facebook and Instagram and body awareness and body comfort and thoughtfulness about comparing yourself to who your peer group is. And so that data just came out today and just really highlights, I think, what we all sort of want to know, which is sort of what to do about those types of experiences. And there's so many things coming at us all the time as clinicians to try to think about what to do and and I just want to say before we start this, and Burt and Evan will say this with me, we will do all we can as clinicians to try to be the biggest hurdle that we can between someone who's thinking about suicide and someone who's making an attempt, or thinking about suicide and someone who's actually committed suicide. But that's kind of all we are. We're hurdles between then and there. And we just want to be as educated as we can and think about screening the best we can to be the biggest hurdle that we can. But sometimes there's just nothing that we can do or would know how to do to stop somebody from committing suicide. I'm sure Burt will talk about that. I don't know if you have anything that you want to say before I go to the transgender? Yeah. Yeah, Jerry Seabrack used to say, you have to really embrace, your lack of control when you're thinking about suicide. But to help us embrace our lack of control, let's think about what we're in control of, right? So with the transgender population, I just want to give you some numbers. So generally speaking, there's about 1.5 million people who identify as transgender or gender nonconforming. And when I'm saying that today, I'm going to say that I'm talking about transgender or gender nonconforming individuals who specifically experience gender dysphoria. These numbers that I'm going to talk about and these risk factors that I'm going to talk about are not going to include the entire LGBTQ spectrum because that's too big. And the risk factors that are related to someone who identifies as a non-heterosexual individual are very different than the risk factors for someone who identifies as transgender. So it's just important to recognize as clinicians that when you're talking about the spectrum, when you're talking about suicidality in particular, I could go on forever about why they're not, but just when talking about suicidality in particular, the risk factors are different. And when I'm going through a couple of them today, might be a little surprised about what's a risk factor for a trans person that you might think is a protective factor. But anyway, about 1.5 million people identify in the states on paper, as transgender or gender nonconforming. Our state of North Carolina is the 12th largest state currently of identified transgender and gender nonconforming individuals across all the states and Cuba divisions that we have. So we are not a small state. So if you haven't begun working with somebody who's transgender or gender nonconforming, you probably will. That means about 44,000 plus, 45,000 plus individuals who are adults in the state of North Carolina on paper, anonymously or otherwise, are identifying as transgender and gender nonconforming. If you're going to add 18 to 24 to that, you're going to go up by another 7, 8, 9,000 people. And if you're going to add 10 to 14 or 14 to 18, you're going to increase your numbers. There are a lot of individuals in the 10 to 14 age range, obviously right now, identifying as part of the transgender community. So at any rate, if you're working in North Carolina as a practitioner, you are going to face, it's no longer really an option to say, I don't feel qualified to work with a transgender person, right? We're going to have to work with transgender people and educate ourselves on how to do that. The highest risk age range for thinking about suicide is 18 to 24, but the highest age range, somebody's with for attempts is 17 to 44. So that's a big age range for attempts to end one's life. The population that is the most at risk are those on the younger side, so 17 to 24, individuals assigned female at birth. Okay, so that would be a little bit different than some other stats we may have on some other populations. Individuals who have lower incomes and lower education rates, individuals who are not partnered, but also individuals among the trans community who do not identify as heterosexual. So if you're a assigned female at birth person, your identification as a heterosexual would be to have a woman as your partner, right? So individuals who are not identifying as heterosexual according to their gender identity or straight according to their gender identity are at higher risk. So that's something sometimes people have to wrap their heads around a little bit, right? Individuals in the trans community identify, typically speaking, and everything I say is a caveat, with their sexual identity according to their transition identity. So just kind of think about that when you're thinking about the individuals that are at highest risk. With the exception of police violence or survival sex, those two things primarily, about 80% of any age group, especially those under the age of 55 who identify as transgender, gender nonconforming, and trans, will be thinking about suicide at any one given time in their life. Okay. About 45 to 60% of people who are transgender or gender nonconforming have been thinking about it within the past 12 months. So suicidality, how to commit suicide, what to do about suicide is something that's on the trans community minds quite a bit. And there are very few things that change those numbers. We try to grapple with control, like I said at the very beginning, to think about, okay, so coming out seems like a really positive thing. Nah, if you come out, you're still thinking about suicide about 80% of the time. Family, rejection, obviously is a problem. But even if you haven't experienced family rejection, you're probably thinking about suicide just about the same amount as someone who hasn't. Committing an attempt, the numbers change a little bit. I'm going to list some protective factors because I think it's more important to think about what's protective than non-protective when we're thinking about this high number of individuals who are thinking about suicide at any one given time in their life. So what are some protective factors? Okay, so having a partner or having friends. Interestingly enough, being part of a support group doesn't count in that category, but having a partner or someone that you would consider a friend. Not getting your medical care, including your psychiatric care, underground. So that means actually not using online mental health or online ways that you get your hormones or online underground. So not getting your medical or psychiatric care underground is a protective factor. Not ever having to engage in survival sex, even in partnerships, to stay married or otherwise, or survival sex, that's a protective factor. And I'm using these loosely. Interestingly enough, I always find this one really interesting, the level of comfort that a transgender person has accepting help from police or public transit workers is a protective factor. So a transgender person who's willing to accept help from police or ask for help when they're in public situations, like on a bus or the T in Boston or otherwise, is a major protective factor. The numbers go down greatly if you're willing to be a trans person or can be a trans person who will reach out to these authority figures for help. And interestingly enough, the T, if you ever lived in Boston, counts as a person of authority. Not being rejected by your carer. This is where we come in. So not ever hearing, of course, egregious things like, oh, I can't do a physical exam on you because I don't know how to touch your body is one thing. But also things that are more subtle, like saying, and I hear this a lot lately, I've never worked with a trans person. I don't know how to do it, from our profession. I don't know. I've never worked with a trans kid, so I'm going to turn down that. So not having had that experience is a protective factor. So I think that highlights to us why we're going to not try to be rejecting or being a carer. And then this is where I'm going to leave you guys with a little hopefulness before we move into screening or questions or whatever Rachel's going to tell us to do. Of course, not being verbally harassed is really positive, but this is where it's a little hopeful for us, right? One of the main things that can be a protective factor, and it drops the numbers from like 80% thinking about suicide to like 43% thinking about suicide. So that's a big drop, is knowing how to advocate for yourself when you've been verbally assaulted or abused. So the sense of being able to know how to role play or think about or have skills in your pocket to manage the day-to-day stepping into the bathroom and maybe being questioned, or the verbal assault that was more aggressive than that when you were at the grocery store or the Target. Having the skills to know how to manage a verbal assault dramatically decreases thinking about suicidality and is a major predictive factor. And I'm going to stop there because I think that makes us all feel kind of good, because I think all of us here can think about, if we can do anything with a trans person, we can do the same thing we do with lots of other people, right? Which is empower them to feel like they know how to advocate for themselves in the context of verbal assaults. Whether that be we're DBT therapists and we use some good stuff, or we're psychodynamic therapists and we, kind of use our good stuff, or we are cognitive behavioral therapists and we alter the way that you internalize the message that's coming at you when you're being verbally assaulted. We can work with that. And it's a big deal because it decreases the numbers greatly. So I bring all this up to kind of be thinking about that and give you guys food for thought. And I'm either going to let Rachel now let us get derailed by asking questions, or I'm going to let Evan and Burt begin to talk about what are we doing to screen. And because we have so many diverse people, of all types, including gender, coming to UNC, we've really had to change the way we screen for suicidality. And that's why I'm super glad that we're switching the tool that we use, which is just better than the tool that we have been using.
So
Rachel, what do you want to do next?
I think it does stop and ask some questions. I know I have some for sure. So one of the points that you brought up, Echo, I'm sorry, I'll go ahead and start because I do have a burning question. And something that was most interesting that you brought up, surprisingly enough, that transgender people are not actually protected against being involved in support groups as far as their suicide attempts or completions go, which is completely counterintuitive to what most of us would assume. And for those of us who are learning more and being adventurous and trying our hardest to serve more of this population and advocate and teaching ourselves how to along the way, we lean maybe heavily on make sure you find a support group and make sure you have your community. And I myself am learning from communities who are learning about this. So kind of worrisome that this might not necessarily be a protective factor. Question, is it a risk? Is it a contributing risk factor or is it just neutral? Do we know?
It's pretty neutral. And Karen, I can see you here. So do being part of support groups make you healthier and better and less self-injurious behaviors? And less cutting and burning and kind of damaging your genitals and things like that, Karen, right? Because you and I do yes, definitely positive. But it's just important, I think, to recognize that for this particular group, that is not a protective factor about thinking about suicide. And for me, it's sort of like the other kind of groups that it reminds me of when we used to try to get a whole bunch of cancer patients together, like ovarian cancer and like breast cancer, and they were young, right? And they'd be like, poop shot, you don't know what, so a lot of it is maybe related to connectivity to who they're in groups with. So it's not a risk factor for sure. And it is really helpful for self-care, compassion, and decreased self-injurious behavior. Doesn't decrease thinking about suicide.
How do you, who do some groups or have lots of patients who are in groups, confront the parental concern that my child is going to learn things from other kids in these groups? That's something I hear all the time. If there worries, whatever it is for adolescents, right? Like if it's eating disorder groups or if it is self-injurious behaviors that we're kind of working towards, the fear that my child is going to learn from kids who are sicker than mine, when in fact maybe they'll be the teacher more recently enough. How do you all address that with families based on what your experiences have been with people's response to these types of groups?
Do you want me to answer that, or do you want Karen to answer that? Karen, do you want to answer? So I would say very simply, they know what they know already, right? That's not how peer. Yeah. So Karen, what is a person who runs a lot of trans groups? Karen, years ago, really got invested in sort of doing self-compassion work, and even though couldn't find funding, because it's super hard to find funding to do anything with trans people, even though it seems like people should fund us, they don't ever. Started up a group, and we are still involved with her. So Karen, do you want to answer that question?
Can you just reframe the question one more again?
I have a lot of parents who are very hesitant to get their children involved in group therapy and support groups because of their fear of learning from others. And this applies to transgendered populations and to any population that is engaging in potential risky behavior and having stigma or shame around it. And so it's like pulling teeth sometimes to get parents to trust the process that peer groups can be supportive and not a place where they learn worse behaviors.
Yeah, actually, the parents that we have worked with were really supportive of their kids getting into these groups. Kind of the opposite of what you're saying. They really wanted their kids to meet other trans kids. And what the trans kids said, what we heard a lot from them was that I've never met trans kids before. A lot of them came from somewhere out in the middle of who knows where, never met any trans kids. And they really seem to get a lot out of being with other trans kids. So it makes me wonder. I was also surprised, Echo, when you said that, but again, it wasn't about suicide. It wasn't.
Remember, it's not about suicide. And Karen, this brings up a conversation, and we're going to not do this whole thing on trans today. Being gender fluid or gender non-conforming is not the same psychological experience as being gender dysphoric and transgender. And the data that I'm presenting you today is on gender dysphoric transgender individuals, right? Mm-hmm. To be gender dysphoric is a little bit like being, Burt, forgive me, psychotic in your own way. It is such an individualized thought experience that it is different, Karen. You know this, like when you're doing your group, there are many people that are in your group who are trans, some are gender nonconforming, some are gender fluid, some of them are identifying as queer, some of them identify as transgender, and they mean that in one way. The data I'm presenting today is from the Williams Institute, where it was very clearly defined as a transgender individual who has a clear documented history of gender dysphoria. Does that make sense, Rachel? So it's very hard to feel part of a group experience when you're a transgendered individual who has gender dysphoria or body dysmorphology, you know, so that's, yeah. So again, I'm going to say, I still send people to groups. We don't get too locked down in this, right? It's just not the solution, you know, to thinking about what might be suicide thinking.
And by the way, Echo, I just wanted to mention, we did get funded finally from AFSP, American Foundation for Suicide Prevention. So we do, and the IRB was just approved like 10 minutes ago. So I'm thrilled.
Good, congratulations. Okay, then just erase everything I said for those people, okay? All right, Rachel.
Well, anybody else have any other questions for Echo before we transition to next year? Dr. Hutto, Burt?
I have sort of an observation that maybe you can comment on. I've seen maybe a handful of young adults, transgender young adults, who've moved to this area from all over the country to have friends here that they've met online, come here, and then those friendships fall apart or something like that. You know, within a couple months, and then the patient becomes suicidal. Again, just an observation. It's maybe a handful of people like that. I guess our area is somewhere I would assume that transgender people do come to as a more accepting place. But I don't know if you have any comments to make on that.
So I would not say our state is more accepting, but I would say that we secretly and on the sly, we do a lot of things in North Carolina for transgender people. I don't know if you guys know this, social transitioning wise, for example, the legal agency in North Carolina has it now that it's not very difficult actually to have your name changed in the state of North Carolina, not on your birth certificate or your social security card, but on all your documents that are important to your daily life, like your driver's license and your passport and your, you know, school registration, right? On your driver's license, you don't have to go through any phase of transitioning to have a professional sign off on you being listed on your driver's license according to your gender. There are, in the state of North Carolina, since 2014, we have been using hormone replacement therapies in people as young as 14. Our endocrinologists have gotten that. Another thing, Burt, is we are, believe it or not, in some ways, a place to be known for bottom half or general GAS, general affirmation surgeries. So there's these kind of strange ways that North Carolina might surprise you. And then also, I think other things are just like many people, just pods, right? So we have pods of people living in Graham and Burlington, I think, because it's affordable, for example, but also accessible to people, who can do mental health care, or medical care or physical exams, right? So we have this geography, right, where again, we have a lot of people who live in Graham and Heflin and Mebane, North Carolina, and they've moved from other places because they are 20 minutes away from a major medical center. So I think there's lots of things that the state of North Carolina has done and the word has spread. And I think some of it is just our geography. We have these places where you can live fairly affordably and then also have access to a medical center. But I think that that's what people say when you're talking to them about why they would move to a place like North Carolina.
Thanks. I wouldn't have thought of Mebane or Graham as being the place that would be most welcoming to Burlington, to be most welcoming to this population. But you mentioned the risk factor or protective factor was having access to, above board medical treatment, just no barrier to access to regular doctors, I guess. And so our area is pretty good about that too, right? Not only at UNC, but in the surrounding community, there are sufficient doctors who provide hormones and everything else to this population?
So it's not, I mean, I don't want to be too Pollyanna-ish, but yes is the answer to that. I think that you can have primary care here in the state of North Carolina. And I think, again, like Karen was saying, you know, at our GWE clinic, our Gender Equity Wellness Initiative clinic, you know, we serve the whole state and South Carolina and Virginia. And I think what we, you know, not the, you know, there is above ground access, you know, to care. I wouldn't say it's always great, but we're doing better than some other states, right? And there's also a lot of tech work here. So if you're a young adult and you want to do kind of like online work, you know, you can work at Research Triangle Park. So there's a number of things, I think. So we were 22nd, then we were 16th, and now we're 12th, and now we're looking like we're going to be 10th in terms of the percentage of people who identify as trans, gender nonconforming are living in this state. So as Rachel said, you know, as us on the screen, we shouldn't expect that we're going to get less, you know, we shouldn't expect that we need to be less knowledgeable, because I think our state is going to continue to grow in accessibility and people. And a lot of them are suicidal.
I like your point though, Echo, that it can't just be you that's caring for all of these people. So I'm seeing that more with therapists in the community. Like there's a whole lot of people who are becoming more comfortable in care. So it's really important we know these nuances. Burt, Evan, do you guys have a preference on who goes next in terms of presenting?
I can go next. Let me see. Hopefully this will work. Does it work? All right, great. So I am talking about suicide screening at the hospital level, and it's I will admit that I feel like a fraud while I present this. So I'm involved in this initiative and this project, but this is really Don Rosenstein's project, and he is spearheading it. He was part of the kind of group at the NIMH that developed the ask and validated it as a tool there. So you have the wrong Jew presenting today, but I will do my best to fill in for the much better Jew in every aspect of life. So for suicide screening, this is transitioning to what is called the ask, and it's the ask with a Q. It is Ask Suicide Screening Questions. But just to back up and give us a little bit of background from sort of how we got here. So the Joint Commission instituted one of these national patient safety goals in July of 2019, which included a bunch of different recommendations. One of them, or two of them, were to have validated and evidence-based suicide screening tools and validated evidence-based suicide assessment scales. There were other things that came in here, like looking at environmental factors, safety factors on inpatient units. But these were some of the main things that we're looking to address from what happened at UNC. So the Joint Commission mandated suicide risk screening for behavioral health concerns. So this could be like if you're admitted to an inpatient psych unit, but it could also be like you take a Tylenol overdose and you're admitted to a medical service, you are still mandated to get suicide risk screening. So it does impact things outside of just inpatient psychiatry. And the Joint Commission recommended suicide screening for all patients, but did not do a mandate for universal screening. So UNC had to rapidly sort of adopt some sort of screening protocol. And what we did as a system was to do universal screening across all entities for all patients that were above or older than 12 years old. And we implemented the Columbia Suicide Severity Rating Scale. I'll just call it the Columbia from here on out. And then that is the screening tool, and the assessment scale is called the SAFE-T. So the Columbia, for some more background on what it is as a screening tool, it was actually identified or used as a research tool. So a bunch of clinical trials sought a way to have a standardized assessment of suicidal thoughts and behaviors. And so that's where it grew out of. It was never designed to be a suicide screener, nor was it ever designed to be used in clinical settings. But that's what we've been using for over 2 years now. It hasn't been validated in children under 12 years old, although at the hospital setting, many children are being screened using this tool who are under 12. It doesn't really help tease apart those that are acutely at elevated risk of suicide versus chronically elevated risk. So some of the questions are about if they have prior attempts. And so if someone screens on past behavior when they were an adolescent, they will always screen as high risk, essentially. The Columbia requires a rescreener. So there's multiple tools to be used. And it doesn't really address what happens if someone is medically ill to such a degree that they can't participate, or if someone refuses to participate. And so what happened from utilizing the Columbia was that essentially nurses had to continually screen and then rescreen people. And we had a bunch of sitters or psychiatric nursing assistants who were used because someone screened as either a moderate or a high risk. And then with that assessment tool that came after the screener, the SAFE-T, it became really confusing who does that, when they do it, and what to do with the results. So here's some data that Don and his group presented to hospital leadership. These are the rescreeners here. And so what you can see is that, I think this is 92% are no risk. And so we're essentially continually rescreening patients who are identified as not being risky at all. And if you include low risk in there, then we're at about 96% of rescreeners aren't an identifiable risk that would need an intervention. Super busy slide. This is the psychiatric nurse assistant utilization. So these are our one-to-one sitters for the past, or for 2020. So you can see by some units where it's most utilized, 6 children, 6 neuro is mostly like the neurology, inpatient service, oncology, bed tower is like inpatient medicine, and then 5 neuro is our kind of child adolescent. And then we're finally getting into some ICU level of cares after there. So the grand total is 110,000 hours. Which equates to 12 and a half years of sitters being utilized in the year 2020. And the need for having sitters was so great that the BHEAD, or the behavioral health component of the emergency department at our main campus here in Chapel Hill, created a whole new role for sitters. And that role in this kind of 8-month period, they looked at the job code, was almost 17,000 hours of use. Which equates to 707 days of using this one single job code in an 8-month period. This is data on the initial screen. And so essentially what we're showing is that most people are going to screen out of it for being at not high risk, essentially, which is consistent with the rescreener. So getting to the ask, and what I've been asked to talk about is this new screening tool that was developed by the NIMH. It is listed by the Joint Commission as one of their approved screening tools, just like the Columbia is. So it includes this protocol where people are screened with a 4-item questionnaire, which is the ask, and that takes nurses less than a minute. And then depending on their responses, they can get a further assessment tool, this brief suicide safety assessment, which is to be completed by social workers. And then depending on results of that, it would screen for a psychiatric evaluation. So this is what the ask looks like. Here are the 4 questions. I won't read them to you. You can read them here. But then there's a 5th question, which is, are you having thoughts of killing yourself right now? And then it gives nursing instructions on what they're actually supposed to do, which the Columbia is kind of unclear about. So it says, if you answer no to all of the 4 questions, you don't have to answer the 5th question. You don't have to ask the 5th question, and you're screened out. So if you answer no to all 4, then you're done, and you never have to rescreen them again. There's no requirement to rescreen like there was with the Columbia. If someone answers yes to 5, you're having thoughts of killing yourself right now, then they are at imminent risk, and that triggers automatic safety precautions and a psychiatry consult for a full risk assessment. And then if they answer yes to any one of the first 4 questions, then they're sort of in this non-acute but still screening positive setting, which is when the BSSA comes in, the brief suicide safety assessment. And so this again is what a social worker would be tasked with completing to then better determine what the next steps or disposition would be. So it could be that someone, from here screens as low risk, or it could be that someone still gets into this imminent or high risk category that needs a psychiatric evaluation. It's said to complete 10 minutes. I again won't read it all to you. There's 3 pages to it, but it's essentially looking at suicidal thoughts, sort of current symptomatology, social network, safety planning, and then sort of making a clinical judgment for what should happen next. So they need an emergent psych eval, they probably need follow-up care, they could be reassessed, but it doesn't automatically buy someone a psych consult. And this gets to the screening pathway for the ask, and we'll compare it on the next slide to what the present screening pathway looks like. So like insinuated a little bit ago, there's no requirement for rescreening here. You could consider it, but there's no requirement. If someone's medically unable, you don't have to ask them these questions, and you would screen them later. And if they answer no to any of the first 4, then they entirely exit. And then this bottom sort of helps to delineate the sort of 3 buckets someone can fall into, either low risk, high risk, or imminent risk. And so again, you can get to imminent directly from the ask if you answer yes, I'm having thoughts of killing myself right now, or you can get to imminent from the social worker assessment. So I think this helps to visualize how much cleaner and hopefully simpler this ask protocol will be than the present Columbia protocol. The Columbia is confusing. There's 4 categories: no risk, low risk, moderate risk, high risk. It's unclear why there's a no risk category at all. Whereas the ask is, I think, a little bit cleaner, and the workflow kind of is better outlined for what providers and nursing staff are supposed to do. So this is sort of like a summary slide comparing the 2 with the different outcomes. And, there's some things we've already highlighted here that point to why we think the ask will be a good switch over from the Columbia. And that's just a summary. So some of these slides were used as a pitch to the medical center. This is like something that's going across all entities. So, Johnston to Pardee are all switching over to the ask as well. I'm more involved on the Epic build side of how to get it across all the systems. But I think it is it'll be a move in the right direction from what the Columbia workflow is.
Challenge, like how to get it across the system, and also how to get people
Right.
to hate you for putting it there, right? Like the safety, like, oh, this is a logistical nightmare in terms of what these prompted, and the notification fatigue, alert fatigue of having these false positives come through. I'm sure it was difficult. Is that improving and anticipated to improve more with the transition?
Yeah, it's anticipated to improve more. I think some of the biggest workflow barriers will be that social worker completing the BSSA, because as we found out, it's not like, I'll pick on Johnston and Pardee, but it's not like they already have someone hired to do that task. And so then a job has to be created. They have to pay someone to do it. A lot of those entities are using telepsychiatry for consults. And so they're essentially contracting out to some third party to do it. And so whether or not they'll continue to do that, or if UNC will take over some of that as a virtual hub with SOA, remains to be seen. But seeing how the different entities practice so differently and trying to get everybody under the same sort of protocol has been challenging and interesting.
I've been I don't know.
Dr. Hutt.
I was perfect. I was going to say if Dr.
Yeah, the hope is January 1. We talked with some of the policy stat people. Apparently changing a policy takes longer than just a few months. So it's unclear if that will actually happen by January 1. Dana, what's yours? The Columbia, I think it was selected just because it's like an easy one to do on the kind of what's approved by the Joint Commission. But I don't know the specifics on why they chose it over the other ones that are approved.
Yeah, Evan, I'll just tell you, because I'm on the committee with Don and I was there during all that, because the CNL, they just came in and told us that was the one we were using. There was no choice involved and no dialoguing involved. It was just, this is what we know and this is what we're using. And Don was really tried to stand up and say, this isn't the way to screen. We definitely don't ask these types of questions to children or teenagers. This is going to lead to a major burden because everybody's going to need a sitter, right? So there was an attempt to try to say, like, let the people who do mental health, have some say in the picking, but that was just didn't.
Yeah, it's amazing to hear on the ethics, on the build side. I met with some of the people involved in the build of it, and they had 48 hours to implement everything. And so it was just like, I guess they chose something and then we have to build it and get it out immediately.
And they came back and said, why is it not? I mean, they were like on it, Evan. They were like, do it now. And nursing was running around. It was chaos. It was chaos.
And at that point, it really is checking the box, right? It's not about patient care. It's about checking the box. Did we say we did the right things, which I think is hard. Echo, was there any discussion on stratifying medically ill patients versus psychiatric patients and those surveys or screening tools needing to be differentiated?
You're being so sophisticated. Okay, there was no age differentiation. There was no location differentiation. There was no differentiation about who was going to do the screening. And there was no differentiation about who the sitters were going to be. It was like, we've got to get this done. You've got 48 hours to do it. We're telling you, you have to use this screening tool. And there was no conversation. And then it happened. Like within 48 hours, everybody was doing it. It was crazy. It was a bit crazy. We had all kinds of patient complaints and providers being like, what the heck's going on? This is not how I want to ask about suicidality. So anyway, this is all to say that thank goodness Don was a dog about persisted, to make this change happen, and that people like Evan and other individuals who are on his committee, Sarah and other people, to make this happen, because we would have just kept going with the Columbia, I think, if it hadn't been for people from psychiatry saying we really needed to do something better.
Yeah.
I also noticed that just in terms of what we do, and of course, you're absolutely right, we do go in much more depth, but no discussion on plans, intent, means, or access to these plans, right? Those would be very clear-cut, easy things to survey and could really stratify people in terms of risk more so, but I was surprised that wasn't included at all in this initial screening tools. So I can imagine very many people who ding as positive are maybe in MITS in the ICU, and what are they going to do? And do they need a sitter? Is it a good use of resources? But all things I'm sure you all thought about. Any other questions for Evan?
I have one. So, or comment that I would assume this will be a very popular change, right? That suddenly not as many sitters, it's easier to administer for nurses and frontline workers. This should be very popular. Is that what's anticipated? No, just because it's different?
There's been some pushback just because it's different. There's been some pushback because you're trying to force like a new protocol on different entities that have already had a workflow to do it. And now you're telling them there's a whole nother assessment on top of it. You might have to figure out a workflow to do this whole BSSA. So some have pushed back about that. Someone even likes the safety and says they don't want the safety to go away. Most people probably don't know what a safety is, but it's just a horrendous tool to use to assess suicide risk. But some people have done like that. And then I think some there's been like meetings in nursing higher ups that sort of change is hard to do now when there's so many people quitting and there's so much turmoil that people don't want an additional change.
I would think this would be one of the reasons people are quitting, is this stupid, screening test that we do.
Right.
Yeah. And
Right.
and that's why I thought it might be popular, is again to give them something much easier to do. But yeah, nothing's ever simple, I guess. And so the end of the road is psychiatric evaluation. And so then when someone gets on a one-to-one through the psychiatric evaluation, to come off of that is just another psychiatric evaluation. Because now to come off, you have to have a safety to support that.
That's right. Yeah, that would be like the comparable workflow, is if someone is requiring a sitter, then they'll get a psychiatric evaluation, to determine what they still need. The initial screener and BSSA timeline will likely be entity dependent, if that makes sense. So it's hard to like mandate a protocol across all the entities when some might need a longer delay to get someone to actually do the evaluation than what maybe UNC will have. I don't think the credentials are I hear your point. It's a good one. I don't think it's necessarily, that's how I think the NIMH has their workflow for like when they are doing these screenings, that's who does it there, but it could be a physician who does it. I mean, if that's what an entity needs, and it could be, someone else.
Yeah, that's why I'm involved in the meetings, right? In my role, right, is to try to think about who could qualify. There are many there, and like you just said, in our opinions here, there are LCSW is one person type who could do this,
right?
But that's not for us or for the entity set in stone, right, Evan? So
that's right. Yep.
Some of it's going to come down to just qualifications in general, and then resources about who can do this. Might have to be a PhD.
Well, it sounds like this screener may pick up more people to be transferred to your unit. So switching gears a little bit in our last couple of minutes here, chat with us more about the crisis unit and what we're seeing there in terms of suicide prevention and awareness and new efforts, things that we might not know about.
Well, I was told I didn't have to prepare, so I didn't really prepare much, but I do have a couple slides, and it's nothing new. I'm just going to try to bring up some ideas and hope that for 10 minutes we might be able to discuss a thought or two. And so I'll just show a couple slides and then stop sharing and see if it stimulates any discussion for a moment. Is an old set of slides I had, and so I just took some of them out of this. Why do people become suicidal? There are all kinds of different risk factors, but sometimes it has to do with interpersonal stress, feeling rejected, or the fear of being alone. Abandonment fears and that sort of thing can drive people to acute suicidality. And so before someone gets to the hospital, how can we manage these things to, potentially prevent some hospitalizations? Here's a sort of a script. I can help you manage these behaviors, but to diminish their cause, we need to help you find better social supports, people to help you with those situations. It's sort of try to engage the patient in thinking about it. If someone does come to the emergency room, it's obviously helpful for the outpatient clinician to be available and offer their assessment. I am going to stop there because I think I want to see if anyone wants to comment on that, because I guess some of you work in the emergency room. I'm curious, how hard is it in the emergency room to reach clinicians who manage patients who show up? Is it I'm just curious how much effort it takes to get people on the line. I know Sarah works there. Sarah, if you want to have a comment.
So my experience with trying to get in touch with outpatient therapists is pretty hit or miss, to be completely honest. I find that either I'm able to get in touch with the therapist, they're very involved and they want to make sure that we're collaborating to provide continued care when the kiddo is ready to leave, or I call, there's a phone tree, I never hear back, et cetera, et cetera. Maybe case management eventually gets a hold of someone to get an appointment. So I've seen a large variety, I guess would be an accurate way to put it.
And of course, that matches my experience once someone does get up into the hospital, that sometimes clinicians have already been involved and we can be in touch with them. They're helpful in decision making and safety planning and giving us the information we need to help us assess the person's acute risk compared to their baseline. But then there are other clinicians who it's hard for me to understand, but I don't know if they just never answer the phone or just anyway. It's interesting to me that there are some people whose patients show up emergently for care and then can't get in touch with the doctor. I don't know if anybody else has thoughts about that.
But I found it really interesting transitioning to private. Kind of the status quo for what happens with emergent care with psychiatrists in the community is like, go to the ER, we'll get back with you within a couple of days. And I was like shocked by that. I was like, wait, we don't need an on-call system. I don't need it. You can, there are systems where you can pay for that. You can pay to have an hourly coverage system in place, which is reasonable. But I was kind of shocked that there's not a standard for that from what I can tell. As far as like those who are therapists in the room, like does that differ between MDs and therapists in the community? We are so strict on that inpatient and academics, and to see it so loosely upheld in community was kind of bizarre to me.
What are you asking exactly, Rachel?
On call after hours, people to be accountable for these folks as opposed to just send them to the ER. It's fine. Like, not only do they need collateral once they're there, but responsive and maybe keeping them out of the ER would be nice.
Mm-hmm.
Yeah, I think that's a resource issue, and also sort of the idea that if there's a place to go for a high risk patient, right, send them to that place, right? Yeah.
But in the past, Rachel, I think you're right that there was more typically an expectation that every physician had a mechanism to be on call or have a colleague stand in for them 24/7. Carry a pager and even people in individual practice had to team up in some way to be available. And it's interesting that I don't know if the medical board standard has changed, or not just medical board, but all licensing boards I haven't seen anyone, reprimanded about that issue that I can recall. And so I guess it's just evolved into the standard that, call me in the morning, tell the patient, go to the emergency room with the expectation that the emergency room will just call me tomorrow. And again, like we were saying, some of them call back, some of them don't. So it's just really remarkable to me how people can be untethered from their outpatient care in, their moment of greatest need. All right. Go ahead. That'd be great. Go ahead.
Sorry, I just have like kind of a random comment that I've noticed from assessments, that often I have kiddos who come into the ED who perhaps their therapist have not come across somebody who has suicidal thoughts that are passive, that are not a plan or an intent, but that is discomforting to them enough that they feel that they need an evaluation in the emergency department. And then I have the pleasure of doing a safety plan with them, and then they're headed home. So I think that's also a fascinating phenomena.
Yeah, I agree. And it, I don't know if it's still the case, but there was a period of time it seemed like the schools were frequently doing that too. That somehow at schools people were deemed some sort of risk to some degree, any degree, and the idea was, well, a psychiatrist has to give you a letter before you can come back to school. I see Echo shaking her head. Yes, I don't know if that's still typical.
That was a great phase. Luckily, we're a little past that phase, but that they need an ED consult for a passive suicidal kid is still is a kind of a cultural mentality, you know, even if they're in outpatient therapy with somebody, which blows our mind.
Kind of goes back to what Evan was talking about, the screening, and it, you know, what are the steps, at what level does someone sort of screen in to really needing, you know, a full psychiatric evaluation versus, you know, a recognition that they might need some assistance, but they're not an imminent risk. And it seems like clinicians at all levels could be more familiar with that stratified, you know, system. That good point, Karen, that I think the school shootings and that kind of thing certainly make people very sensitive to any sense that there's a dangerous child in the midst. Yeah. Well, to me, it looks like it's almost 6 o'clock, and so Rachel?
Yeah, well, I just had one quick last question. Bert, are you guys still using the safety plan on the units? It's been the same for a little bit now. So that's a question that I always have is, contracting, we know it's not a plan. Like they're not going to pinky promise they're not going to do anything, but the safety plans I do take seriously with my clients, and especially with the kiddos or adolescents, they're not taking them seriously a lot of times, and I have to really nudge pretty hard to get parents to do so. What's the threshold that right now we're doing in the ED to send somebody out? Like, are they having written documents ever? And on the units to be able to leave, are we forcing that to be reviewed with a nurse or a provider at all? Or is that anticipated that we just concepts and you get it and you're able to leave?
It's not as consistent as I think we could be. And the one that we use, I think they're probably better ones. I've heard that they're, you know, people have been developing these ideas, and there might be a better form to fill out now, but, you know, we use them mostly with people who are, you know, appear to be more cooperative, where it seems likely that they will take it seriously and they want to have that with them. And then sometimes use it with people who are not cooperative as a way to sort of pin them down that this is their statement before they get to leave the hospital, that they sort of agreed that these are the things they'll do when they are feeling unsafe. But it's probably worth reviewing within all of our inpatient services, and maybe in collaboration with the emergency room, what is the best safety plan? Because I do think there's some published ones now, and some probably are better than others.
I can only speak for myself. I've done a fair amount of research on what safety plan would be best for my population, and I've actually made up my own, which is a combination of a couple different one, but is largely based on the one by I think it's Brown and Stanley or something, and that one has a lot of research behind it, but didn't also include one of the bigger factors in some research articles, which was reasons to live. And so I went back and created my own document that's a little more, I guess, friendly, in my opinion, to my conversation style, and giving the kiddos something they can walk home with. And then if I'm just meeting that kid for the for one time in doing a safety plan, I like to go over it with the kid and then meet with the kid and the parent and kind of have a conversation about it and how can we apply this when we get home. And this is a document that needs to go to your next therapist and needs to continue to be evolving. This is just the starting line, but I can't speak to what is happening when individuals go upstairs, and have also been trying to find ways to bring safety plans that have been created upstairs, downstairs. I say downstairs to the emergency department, just for continuity. So I can, you know, specifically go to this kiddo and say, like, you made this great safety plan, but it didn't work. What's going on? Because I've been able to have the pleasure of doing that with a couple kiddos that I've seen come and go. This is all just, you know, my own experimentation though, so with a grain of salt, of course.
Well, yeah, Dana's pointing out if we had it in the chart, it would be available. There you go. So passport.
I like that idea.
Yeah. Okay.
Sarah, you may find some of us emailing you afterwards to compare yours with ours. I made mine also. Honestly, Burt, I think I made one for the private unit years ago, and I think that got passed around now. And it's at this point, you're kind of pulling from who has data. And then most of mine, I got from the VA and added more to it since they were using the Brown as baseline as well. But interesting stuff. Any last comments or thoughts before we do close out for the evening? No? Well, thank you all so much. This was a great conversation tonight. I appreciate all three of our speakers and everybody who chose to join. Join us again next month. Sam will have to remind you who's coming on next month, but I'm sure you will have a really good speaker then. So great to see you all. Thanks so much for your time. Have a good evening.
Thank you all. Thanks so much.
Right.
Thanks.